Pay attention here. Disorders of coagulation are not difficult, but they are tricky. Exams don't ask big paragraphs. They ask small details, definitions, causes, drug choices. One small confusion and the MCQ is lost. So don't rush this topic. BNF Chapter 2, Thrombosis, Stroke, and Disorders of Coagulation. Let's start. Venous thromboembolism, or VTE, is not one disease. It is a spectrum. It includes deep vein thrombosis, which we call DVT, and pulmonary embolism, or PE. The basic idea is simple. A blood clot forms inside a vein. That clot partially or completely blocks blood flow. And remember this golden line, VTE is common, serious, and largely preventable. That is why examiners love it, and that is why doctors must respect it. Many cases of VTE are hospital-acquired. They occur within 90 days of hospital admission. So whenever a patient is admitted, your brain must immediately think VTE risk, bleeding risk, prevention. Now let's understand who is at risk. Think of anything that slows blood flow, damages vessels, or increases clotting. Surgery, trauma, prolonged immobility, especially bed rest, cancer, obesity, inherited or acquired hypercoagulable states, pregnancy in the postpartum period, very important, and hormones, combined oral contraceptives, and HRT. If you remember Virchow's triad, you'll never forget these risks. Now let's focus on deep vein thrombosis. DVT is the most common form of VTE. It usually affects the deep veins of the legs or pelvis. But don't forget, it can also involve upper limbs, intracranial veins, and even splanchnic veins. Clinically, DVT often whispers before it screams. A patient may have unilateral leg pain, swelling, tenderness, skin color changes, prominent superficial veins, one leg, not both. That asymmetry is important. Now here's the danger. A DVT can break free. It can travel. And when it reaches the lungs, it becomes a pulmonary embolism. Pulmonary embolism blocks pulmonary blood flow. Gas exchange fails. The patient struggles to breathe. They may present with chest pain, shortness of breath, and sometimes hemoptysis. And in severe cases, collapse, shock, hypotension, tachycardia. If PE causes hemodynamic instability, there is no debate. Immediate hospital admission. Emergency. Now let's talk about something very powerful, prevention. Every single patient admitted to hospital must be assessed for VTE risk and bleeding risk. This is not optional. We use validated tools like NICE guidance. Thromboprophylaxis comes in two forms, mechanical and pharmacological. First, mechanical methods. Anti-embolism stockings apply graduated compression. They improve venous return. They are worn day and night until the patient is mobile. But be careful. They are contraindicated in conditions like acute stroke, peripheral arterial disease, peripheral neuropathy, severe leg edema, and local leg conditions such as gangrene or dermatitis. Another option is intermittent pneumatic compression. It can be used alone or alongside stockings. Now, pharmacological prophylaxis. This should start as soon as possible, usually within 14 hours of admission, but only if the VTE risk is greater than the bleeding risk. We avoid or delay anticoagulants in acute stroke, thrombocytopenia, and untreated bleeding disorders. If anticoagulation must be interrupted, for example around surgery, temporary prophylaxis should always be considered. Let's move to surgical patients because exams love them. If possible, regional anesthesia is preferred over general anesthesia. It reduces VTE risk. Mechanical prophylaxis is offered in many surgeries: major trauma, cranial surgery, abdominal, bariatric, thoracic, cardiac, ENT, and spinal surgery. Prophylaxis continues until the patient is mobile or discharged. But note this carefully. For spinal injury or cranial surgery, it continues for 30 days. Pharmacological prophylaxis is used when VTE risk outweighs bleeding risk. Low molecular weight is the workhorse, suitable for almost all. Unfractionated heparin is preferred in renal impairment. Fondaparinux is used in selected surgeries like abdominal, bariatric, thoracic, and cardiac surgery, and in lower limb immobilization or fragility fractures. Duration matters. General surgery, at least 7 days or until mobile. Major abdominal cancer surgery, 28 days. Spinal surgery, 30 days. Hip replacement has specific regimens. LMWH followed by aspirin, or LMWH with stockings or oral agents like rivaroxaban, apixaban, or dabigatran. Knee replacement is shorter, usually 14 days, with aspirin, LMWH, or DOACs. If drugs are contraindicated, use mechanical methods. Now, medical patients. The choice depends on the illness, the patient, and local policy. High-risk acutely ill patients usually receive LMWH first line. Fondaparinux is an alternative. Minimum duration is 7 days. In renal impairment, doses must be adjusted or unfractionated heparin used. If drugs are contraindicated, mechanical prophylaxis until mobile. In acute stroke, remember this clearly. Intermittent pneumatic compression is first line. Start within 3 days, continue for up to 30 days or until mobility returns. Now pregnancy, a very exam-important area. LMWH is offered when VTE risk exceeds bleeding risk. This applies during pregnancy and up to 6 weeks postpartum after miscarriage or termination. After delivery, LMWH is restarted 4 to 8 hours later and continued for at least 7 days. Mechanical methods are first line if drugs are unsuitable. Now let's briefly discuss treatment, not prevention. Suspected PE with instability, emergency referral. Non-drug treatments include elastic compression stockings for symptom relief after DVT, but they do not prevent recurrence. In selected cases, we may use IVC filters or mechanical thrombectomy. Drug treatment starts with anticoagulation. If diagnosis is delayed, interim anticoagulation is started. Baseline tests are essential: blood count, renal and liver function, PT and APTT. First-line treatment options today are DOACs, apixaban or rivaroxaban. Alternatives include LMWH followed by dabigatran or edoxaban, or LMWH with a vitamin K antagonist. Unfractionated heparin is reserved for renal impairment or high bleeding risk. Duration of treatment is key. Minimum is 3 months. In active cancer, 3 to 6 months. If VTE was provoked and the risk factor is gone, we usually stop at 3 months. If unprovoked, long-term anticoagulation may be needed with annual review. Patient education is not optional. Patients must understand duration, side effects, interactions, monitoring, travel advice, dental procedures, and they must carry an anticoagulant alert card. Finally, remember this: VTE is dangerous, but it is also preventable and treatable. If you think clearly, assess risk properly, and choose the right prophylaxis, you will save lives and you will score marks. All right, my dear students, pause for a moment. Because stroke is not just another chapter. This is a life-saving topic in exams and in real wards. If you understand stroke clearly, you think like a clinician, and that's our goal. Stroke carries a very high risk of morbidity and mortality. So the first rule is simple and non-negotiable. Any patient with acute stroke symptoms must be transferred to hospital immediately. No waiting, no home treatment, no delay. Why? Because time is brain. Accurate diagnosis of the type of stroke is essential because treatment is completely different, and treatment must start urgently under a specialist multidisciplinary stroke team. This chapter covers 3 conditions: transient ischemic attack, TIA, ischemic stroke, intracerebral hemorrhage. Let's take them one by one, calmly. Transient ischemic attack, TIA. Think of TIA as a warning shot. Symptoms appear, then resolve, but the risk of a full stroke is high. So if you suspect a TIA, do not wait for confirmation. Give aspirin immediately. If the patient is allergic or intolerant to aspirin, use an alternative antiplatelet. Once the diagnosis is confirmed, you move straight into secondary prevention, and you follow the long-term management plan for ischemic stroke. Never ignore a TIA. It is the body asking for help. Ischemic stroke, acute management. Now focus. This part is very high yield for exams. The key drug here is alteplase. Alteplase can be life-changing, but only if used correctly. It is recommended within 4.5 hours of symptom onset. Before giving it, intracranial hemorrhage must be excluded by imaging. It must be given by experienced staff, preferably in a specialist stroke center. Never forget this sequence. Exams love it. Now about aspirin. Aspirin should be started as soon as possible, within 24 hours, but only after hemorrhage is excluded. If the patient has a history of aspirin-related dyspepsia, add a proton pump inhibitor. If aspirin is not tolerated, use an alternative antiplatelet. Now, an important warning: anticoagulants are not recommended instead of antiplatelets in acute ischemic stroke. They may be used only if the patient has a high risk of DVT or PE. Warfarin has no role in the acute phase. If the patient has atrial fibrillation with a disabling stroke, give aspirin for 2 weeks, then consider anticoagulation later. For patients with prosthetic heart valves, if hemorrhagic risk is high, stop anticoagulation for 7 days and substitute with aspirin. What about blood pressure? This is where students often panic. Do not treat hypertension routinely in the acute phase. Only treat if there is a hypertensive emergency or if blood pressure must be controlled before thrombolysis. Long-term management, TIA or ischemic stroke. Now we shift from rescue to prevention. The goal is simple: reduce the risk of further cardiovascular events. If there is no atrial fibrillation, first-line treatment is clopidogrel. If clopidogrel is not suitable, use aspirin plus modified-release dipyridamole. If both aspirin and clopidogrel are unsuitable, use modified-release dipyridamole alone. If that is also unsuitable, then aspirin alone. If the patient has atrial fibrillation, they must be reviewed for long-term anticoagulation. Statins are essential. Start a high-intensity statin like atorvastatin about 48 hours after the stroke. If the patient was already on a statin, continue it. One more exam pearl: beta blockers are not recommended routinely after stroke. Use them only if there is another clear indication. And never forget lifestyle advice: diet improvement, exercise, weight control, reduce alcohol, stop smoking. These are not soft points. All right, let's dive into these drug groups. Stay focused. This is super important for your exam. Let's start with anticoagulants. The main idea is simple. These drugs prevent thrombus formation or extension. They work best in venous circulation, where blood flows slowly and clots are rich in fibrin, platelets, and red blood cells. They are less effective in arterial circulation because fast-flowing arteries mainly form platelet-rich clots. Before giving any anticoagulant, patients must always receive verbal and written information. They need to know when to seek help, what bleeding signs to watch for, and that head injuries require emergency referral. Safety first, always. Oral anticoagulants, vitamin K antagonists are the classics: warfarin, acinocumarol, phenindinone. These drugs work by inhibiting vitamin K, which reduces synthesis of clotting factors. Important points: onset, 48 to 72 hours. If you need rapid effect, give heparin concurrently. Not first line for cerebral artery thrombosis or peripheral artery occlusion. Aspirin is preferred. Target INR varies. INR 2.5, DVT, PE, AF, cardioversion, mitral valve disease with AF, bioprosthetic valves, MI, acute arterial embolism. INR 3.5, recurrent DVT or PE despite anticoagulation. Mechanical prosthetic valves, INR adjusted by valve type, location, and risk. Sometimes add antiplatelet if embolic events occur. Bleeding management: major bleeding, stop warfarin, IV vitamin K1 plus prothrombin complex concentrate, INR 8 with minor bleeding, IV vitamin K1, restart when INR 5, INR 5-8 with no bleeding, withhold 1 to 2 doses, reduce maintenance dose. Perioperative management: stop warfarin 5 days before elective surgery, oral vitamin K1 if INR 1.5 the day before surgery. High thromboembolism risk, bridge with LMWH. Emergency surgery, IV vitamin K1 high prothrombin complex. Direct-acting oral anticoagulants, DOACs, are the modern heroes. Examples: apixaban, dabigatran, edoxaban, rivaroxaban. Mechanism: dabigatran inhibits thrombin, the others inhibit factor XA. Indications: non-valvular AF, DVT, PE treatment and prevention, VTE prevention after hip-knee surgery. Rivaroxaban, prevention after ACS or in PDD. No routine monitoring required, half-life 12 to 24 hours, missed dose reduces effect. Reversal agents: dabigatran, idarucizumab, apixaban and rivaroxaban, and dexanet alpha. Parenteral anticoagulants. Heparin, fast, short-acting, ideal for high bleeding risk because effects stop quickly. Low molecular weight heparin, LMWH, dalteparin, enoxaparin, tinzaparin, preferred for prophylaxis and treatment of VTE. Less risk of heparin-induced thrombocytopenia. Longer half-life, once daily dosing possible. Also used in ACS, less preferred than other agents. Other parenterals: heparinoids, danaparoid, DVT prophylaxis, alternative in AT. Argatroban, after thrombocytopenia resolves. Hirudins, bivalirudin, ACS, PCI. Heparin flushes, often unnecessary, saline is enough. Epoprostenol, vasodilator, inhibits platelets. Iford infusion, fondaparinux, synthetic factor XA inhibitor, antiplatelet drugs. Now switch gears. Antiplatelets are for arterial clots. They inhibit platelet aggregation. Remember, arterial thrombi are mostly platelet-rich, so anticoagulants alone aren't enough here. Primary prevention: low-dose aspirin, not recommended routinely. Secondary prevention: long-term aspirin recommended if cardiovascular disease exists. Add a PPI if high risk of GI bleeding. Common drugs and uses: aspirin, stroke, MI, ACS, CABG, stable angina, intermittent claudication, post-coronary stent. Clopidogrel, ischemic stroke, AF if warfarin unsuitable. Dual therapy with aspirin increases bleeding risk. Dipyridamole, secondary prevention post-TIA or stroke. Prasugrel, ticagrelor with aspirin, ACS plus PCI, usually up to 12 months. Cangrelor IV during PCI if oral therapy not suitable. Glycoprotein 2B3A inhibitors, specialist use abciximab, eptifibatide, tirofiban, usually during PCI with heparin, aspirin plus clopidogrel. Coronary stents, dual therapy, aspirin plus P2Y12 inhibitor is mandatory. Bare metal stent, at least 1 month, clopidogrel plus aspirin. Drug-eluting stent, at least 6 months, clopidogrel plus aspirin. Premature discontinuation, high risk of stent thrombosis. Friends, here's the big picture. Anticoagulants prevent clots in veins. Think slow flow. Fibrin-rich antiplatelets prevent clots in arteries. Think fast flow. Platelets. Safety, patient education, and timing are just as important as the drug choice. Master these concepts and you will think like a doctor, not just a student. Remember, every dose you give or advise can save a life or prevent a stroke. And that, my friends, is why this chapter matters. You are doing great. Keep going. Step by step, drug by drug. All right, friends, that's all for today. If this lesson helped you, like the video, share it with your friends, and subscribe so you don't miss the next class. Next video, hypertension. Very common, very exam important. Stay focused. See you next time.